All right. So, uh, today I just want to talk about a couple topics. Maybe some of us don't really understand the difference between BiVs, ICDs, and BiVs pacemakers and BiVs defibrillators as well. And I just want to talk uh, about the antiarrhythmic medications. It's really a recurrent topic, and we had over the weekend issue with a patient where he was given a medication that he was not supposed to be given based on the ejection fraction. So just these two topics are really important, and we can touch up on any other topic that we need to talk about. But first of all, good afternoon, everyone. I think now everybody is tuning in. Thank you very much for what you do. And then we've not been doing this for a while because of everybody was busy, but now I think we're going to come back to schedule and then try to do it at least twice a month. So to go into the topic directly, as you know, devices are indicated for multiple reasons. One of them, pacemakers, if you have slow heart rate, and ICDs, if you have decreased ejection fraction, or if you have history of sudden heart arrest from arrhythmias. There's an indication for BiVs when you have desynchrony in the heart. In other words, when you have wide QRS duration on your EKG, indicating that the septum and the lateral wall of the left ventricle, they really don't squeeze at the same time. So instead of squeezing at the same time, so they squeeze, there's some difference in between in timing between the squeeze. This is why when you add BiV, you add wire on here and the other lead on the other side. So the two leads going to deliver electricity at the same time. That's going to force the heart to be in sync. I really want you to remember one thing. BiV pacemakers, or what we call CRTP pacemaker, that is an indication for synchronizing the heart when ejection fraction above 35%. When your ejection fraction below 35%, you have to do a defibrillator, which is CRTD for defibrillator. And that's totally actually different indication. So the CRTD defibrillator is going to have pacing capacity as well as defibrillation capacity. And the CRTP is going to pace the heart and synchronize the heart without the defibrillation need. Now, if you really talk about the need for ICDs, the ICDs are indicated, or defibrillators are indicated when the ejection fraction less than 35%, because simply when your ejection fraction below 35%, your sudden heart arrest will increase. We tried to tease out patients who are in need for defibrillators for many, many years, and tried to identify patients who are at high risk of sudden heart arrest. The only risk factor for sudden heart arrest is really decreased ejection fraction, i.e. ejection fraction less than 35%. Now, if you're sudden heart arrest survival, then in that case, defibrillator is needed for secondary prevention, not primary prevention. But if your ejection fraction less than 35%, then AICD is needed for primary prevention. Now, the CRTD, as in David, is indicated again in ejection fraction less than 35%. CRTP is indicated if your ejection fraction between 35 to 50%. Now, any patient I know that the pacemaker need in the right ventricle is going to be more than 40%, I always do CRTP, which is BiV pacemaker. Because the outcome is much better. However, if let's say if we're going to do AV nodal ablation for pacemaker for patient, then I would try to do CRTP, which is the BiV pacemaker on this patient. And we had a couple of patients that wrongly had some kind of orders written as CRTD, which is BiV ICD, which is not really needed if ejection fraction is less than 35%. So just keep that in your mind. Now, if you look at the guidelines, anything above 35% pacemaker of any kind is okay if you need a pacemaker. But if you have your mom or some of your relatives or somebody you care for, which is, you're going to treat your patient as family, in that case, you try to do the right things, which is, adding the extra wire, which is the LV lead, to make sure that the heart is synchronized. Do you guys have any questions about that? Is it really clear? All right. We can talk about indications for ICDs, defibrillators, and BiVs at other point, but I want to just touch up on that. Now, the antiarrhythmic medications, there are classes of antiarrhythmic medication. I really don't want to, bore you with the classification, but there are certain stuff that you have to keep in your mind. Number one is the class 1C medications, such as flecainide or propafenone. These two medications, they are used in atrial arrhythmias, mainly atrial arrhythmias. Sometimes we use them for PVCs, mainly for atrial arrhythmias. You have to make sure that your patient does not have history of coronary artery disease or decreased ejection fraction. Always keep that in your mind. Flecainide, propafenone are indicated in atrial arrhythmias, sometimes PVCs. If your patient has decreased ejection fraction less than 50% or history of CAD or history of MI in the past, these medications are contraindicated. Black box warning based on CAS trial in 1992, where they found that increased mortality in these kind of patients. So just keep that in your mind. We had a patient over the weekend was actually started on propafenone. Ejection fraction was 35% or so. That was a mistake. We should not do that. Always remember, it's a fact, and it's very, very easy to have, God forbid, if some bad outcome, lawsuit happened, and that's really not fair for our patient. Now, the other heart rhythm medications, such as amiodarone, you can use it everywhere. You can use it for atrial arrhythmias. You can use it for ventricular arrhythmias. The only issue with amiodarone is the fact that it's toxic medication over long time. So it has this cumulative effect of toxicity, affects the eyes, thyroid, lung, and liver. All right. Now, for nursing home patients, is kind of ideal, to be honest with you. The reason it's ideal, because you don't really expect your patient to survive beyond 10, 15 years, right? So the likelihood of having toxic effects from this medication is very small. So it tends to be safe medication. You can use it if the ejection fraction is low, if you have CAD, if you have history of heart arrest, you can use it anytime. And sometimes, actually, if you have patient with atrial fibrillation and borderline blood pressure, you can't use cardizem or metoprolol or beta blockers or calcium channel blockers. In that case, actually, this medication can be used. Amiodarone can be used for rate control, not only rhythm control, because of the beta blocking effects of the amiodarone. So just keep that in your mind. There are other medications, which are the class 3 medications, potassium channel blockers, such as sotalol. Sotalol, we don't like to use it if ejection fraction below 50%, but it's safe to be used if ejection fraction above 50% and if you have coronary artery disease. It's safe medication. Sometimes we use it for atrial fibrillation management. Rarely we use it for ventricular tachycardias. Always remember that it's renally cleared. So you have to dose your medication based on GFR. So if your GFR below 50, you might need to use the medication once a day, and you can titrate up this medication as needed. Always look at your QTC interval, and if your QTC interval above 500, you have to adjust your medication. When you calculate your QTC interval, remember that ORS duration is included, right? So if you have paced heart rhythm or you have bundle branch block, you have to take out about 80 milliseconds from your calculation. Okay. So if you have somebody paced rhythm or right bundle, left bundle branch block, and the QTC interval is about 550, always remember that you really need to take about 80 milliseconds or so from the QTC interval, because of part of the delay, not the repolarization, but the part of the delay is really the QRS prolongation. The Phytilide in general is medication affects mainly the atrium. Dophytilide is kind of reasonable medication to be used. However, dophytilide has to be started while you're at the hospital. You have to renally dose it, and you have to get EKG about 2 hours after starting the medication. So you know, you have to take it like you have 2 doses a day. You have to get EKG, you know, within 2 hours after each dose of this. And usually we don't really use it in the nursing home facilities, but we might use it at the hospital. Interesting enough, I started actually a lady the day before yesterday on the dophytilide. Yesterday they called me that her QTC interval was 550. So I told them, well, let's cut down on the dose. Before the second dose, patient went into torsades. So we had to stop the medication. Now she's actually in AFib with RVR. In that case, you know, the only thing I can do for her is, because she has extensive scarring in her left atrium. So the only thing we can do is just AV nodal ablation and bivalve pacemaker. So that's dophytilide. So we talk about dophytilide. Dophytilide can be used in CAD, in congestive heart failure, to treat atrial fibrillation. Dophytilide is exactly the same as amiodarone in terms of use. The only difference is the fact that it's renally cleared, so you have to watch for your kidney function. And secondly is the fact that it has to be done in the hospital. The other medications such as Mexiltin and procainamide, you know, these medications can affect mainly the ventricular tissue, and rarely we use procainamide. Mexiltin, I use it every once in a while. Mexiltin usually does not really prolong your QTC interval. Another thing I really wanna talk about, if your ejection fraction less than 50% is really contraindication to use cardizem or verapamil. You really need to remember that. Okay, unless, now here's what we can there's an exception. If you're treating somebody at the hospital, ejection fraction 20%, and this patient having AFib with RVR after hip surgery or whatever, then using IV cardizem for a short period of time is reasonable, right, to control the heart rate. But it's really class 3 indication, which is contraindication to use these medications long term if your ejection fraction below 50%. I think some of us really forgets that. Always make sure that you know these facts, because these facts are facts that should be known if you're practicing cardiology, and it's easy, God forbid, if bad outcome happen, to come to surface on board and hunt us down. So remember that. Always try to figure out ejection fraction. Always try to figure out ejection fraction. A lot of stuff is really based on ejection fraction. In cardiology, we love echocardiogram. Why? Because echo can give you ejection fraction, and a lot of our medications right now are actually based on your ejection fraction, right? Now, when you talk about congestive heart failure, you always remember to talk about what kind of heart failure you have. You know, heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. Not really from prognostic indication, but from the fact that really management and pathophysiology is different, right? The HFrEF or reduced ejection fraction, you know, the MRA, the ARNI, the ACE inhibitors, ARBs should be used, right? As well as metoprolol, or as well as beta blockers, which is carvedilol, metoprolol XL, or bisoprolol. And these medications are standards of care and has to be used, right? However, heart failure with preserved ejection fraction, we really don't have much medications, but we have 2 medications proven to be actually effective. One of them is really the aldactone. So the MRA, these medications are should be started, and you have to be careful always. If you work with me in the clinic, that I always order Campanil within 1 to 2 weeks. Whoever actually works with me in the clinic, we had, patient recently, healthy otherwise, we check his potassium, like was 5.4, 5.5, 5.6, something like that. And that happened after starting the aldactone. So always remember that you need to check Campanil within 1 to 2 weeks, standards of care. The other medication that we can use for HEF is one of these SGL2 inhibitors, such as Farxiga or Jardiance. There's actually there are some clinical trials came recently that these medications are effective in reducing heart failure readmissions and in actually improving quality of life and survival. So always remember, if there's a way you can start these medications, to be able to start them. You may get some pushback from nursing homes because of the financial aspect. They are a little bit expensive, but nothing wrong if you can try to use these medications. If you feel that your patient is, blood pressure is a little bit borderline, you're doing everything you can to diuresis this patient, but still not medically optimized. In that case, there's an argument for these kind of medications. GFR should be above 25 for these medications, for Farxiga or Jardiance. And Jardiance may be 30, Farxiga is about 25, and you always remember that they're going to shed a lot of sugar in the urine, so the likelihood of having infections and yeast infection and bacterial infection in the urine is very high. So they really just need to keep an eye on the hygiene of these areas and drink water. So I just want to touch up on this because, it's kind of emerging. This is why I really did not choose to make a topic today, but it seems to me every once in a while I really need to remind you guys about these aspects because, us as the providers in cardiology, we should really be aware of this. Everybody works with me knows that I really don't like digoxin. I hate digoxin. If you really need to commit to digoxin, you have to check digoxin level every once in a while. Okay, we've seen it multiple times that, the patient become toxic from the fact that, elderly people, they have variations in their GFR. Digoxin is cleared by the kidneys, has long half-life. All of a sudden, your level is 1.4, 1.5. Your patient's having PVCs and non-sustained VTs for no reason. Guess what? Probably the reason is digoxin. So it's old medication. I don't like to use it. Old cardiologists and old primary care physicians, for whatever freaking reason, they love this medication, but we hate it. So if there's a reason for you to stop this medication, please do. And, nobody should be bothered. I use it sometimes in the hospital if somebody with hypotension, after surgery or whatever, you give them dose of 0.5, it will buy some time for the amio or whatever to work. But we should not really use it long term unless absolutely needed. And I really need to know what kind of absolute indication for digoxin. Do you have questions, guys?
I wanted to bring up one interaction that you didn't mention, and
Yeah.
that we came into in clinic practice: Coumadin and amiodarone.
Yeah.
And INR. Because I know we don't use Coumadin that much, but for people who have metal valves, it can come up if they have AFib too.
Yes, so basically the interaction happens, and the teachings is to adjust your Coumadin dose by 30 to 50% if you're going to start amiodarone, right? And that's really always, you need to remember that. What you have to do about it, either you adjust the dose or you can tell your patient, within 4 to 5 days you need to have an INR check. Let me tell you something. When I was in training in 2006, 2007, 2008, internal medicine, I remember a lady in Houston that, hey, doc, we didn't have DOACs at that time, and said, I want to inject myself every day, twice a day with Lovinox because I really do not want to be on this rat poison because I love my salad. You know what? That was a mistake because we don't really do, diet teachings anymore. We tell patients, eat whatever you want to eat as long as you can keep the same amount of greens or same amount of food. But if you're going to take Coumadin and do binge drinking every 2 to 3 weeks or every weekend, and if you're going to decide that, hey, next week you're going to eat only greens and the week after you're whatever, no, that's not going to work. You have just to have a stable diet. And, because Coumadin, warfarin, as long-acting medication, half-life is about 30 plus hours. So, if you're going to adjust your diet and you're going to eat almost the same thing on weekly basis, that should not really have major issues, major impact. But that's very important, the amio and the Coumadin interaction, and that happens, actually. You're right.
You were talking about the cardiomyopathies. I had a patient actually this week that I saw with Takotsubo who had reduced ejection fraction. She was put on guideline-directed medical therapy, had improvement in 10 days. Her EF was back to normal. Now she's in the facility and she's having horrible orthostasis, likely due to the high dose Entresto that she was on. And I was trying to do some research and I couldn't find anything about once you have normalization of your EF post stress-induced cardiomyopathy. It didn't seem like there was really indication to continue the meds.
So yes, let me tell you this. When it comes, and if I was in your shoes, I would stop the medications. Right? Here's what we know. There are stages of heart failure. You have stage A when you have risk factors for heart failure, hypertension, diabetes, you don't have insult to your heart. Stage B when you have decreased ejection fraction or stiffness, diastolic dysfunction, but you don't have clinical heart failure. Stage C when you have symptoms and decreased ejection fraction, or you have symptoms and diastolic dysfunction. And stage D when you're on transplant or class 4 heart failure. Now, the teaching is it's one-way street. It's one-way street. When you go to stage C, there's no going back, even if you normalize your ejection fraction. The only exception is really Takotsubo cardiomyopathy. In fact, we have actually one of the famous attorneys in Jacksonville, his wife is patient of us, and whenever she gets upset about $5, $6, $7 million, she gets Takotsubo, and she's very hypotensive. So I told her, you know what, just to stop the damn medication and hopefully teach yourself not to get very upset about stuff, and it's reverse. So back into this, although it acts like stage C heart failure, but it's really not stage C, is totally reversible. And I would stop medications, shake the hands of the lady and tell her, you know what, try to not to make yourself upset about stuff, and that might actually recur. If recurs, we'll treat it as such. I think my opinion about it, even though the teaching and the guidelines would say that you have to be on guideline-directed medical therapy if your ejection fraction below 30% or 35 or 40 or whatever, 50%, until, regardless of how you feel about it or pathophysiology. But for Takotsubo cardiomyopathy, stress-induced cardiomyopathy, regardless of how you feel about it, between 8 to 12 weeks, you're going to normalize. And I think the normalization is part of the natural history of the disease, not because of the Entresto or whatever metoprolol that it was started on this lady. So I would stop these medications and I would reassure the lady and go from there. What happened? How did she get the Takotsubo?
She had actually recently been diagnosed with AML.
Okay, yeah, I get
So
that.
she was being treated. It was like a very quick process. So she was getting chemo and then she ended up septic, and they think she's on antibiotic, IV antibiotic. She had a pacemaker previously that's now potentially infected. She's real sick.
Yeah.
So she had good reason for Takotsubo, but when I was looking through all her records, she had, like I said, 10 days later normalized, and she said the cardiologist at Moffitt had told her, well, you're at high risk of having recurrence, so we want to keep you on Entresto for life.
Yeah, I don't think Entresto is going to prevent the recurrence from happening.
And that everything I read was consistent with that. And so I told her we were going to stop it at least temporarily so she could participate in rehab, because she couldn't even stand up.
Agree. Yep.
So
That's
everything I was reading. So I was just making sure there wasn't something new out there that I didn't know about.
no, actually, that's exactly what, that's the natural part of the natural history of the disease. When you get Takotsubo, you get a huge surge. You know how it happens and how they knew about it? When I was in training in Houston, we remember like multiple patients, they get actually subdural hematoma, or they get subarachnoid hemorrhage. And this blood actually touching the hypothalamic area, where you get surge of epinephrines, right? And they found these patients actually, they get like exactly similar to Takotsubo. So yes, the same pathophysiology, in the sense that you have huge surge of, and the surge is going to stun the myocardium, and the myocardium is going to go to sleep, right? No matter how you do about it, I don't think the Entresto is going to help. In my opinion, I think it's part of the natural history of the disease. Probably we treat ourselves when you start Entresto or Carvedilol or whatever. But I think regardless how you feel about it, the insult is really not myocardium itself per se. It's actually the other factors that affect the myocardium. Similar to when you have tachymedia cardiomyopathy. You treat the tachycardia, ejection fraction improves regardless of how you feel about it, regardless of how you Entresto, Carvedilol, or whatever you're doing, because the insult was the tachycardia, not the myocardial issue itself.
Thank you. That's what I was thinking too. Just making sure.
Shut up.
Any other questions, guys?
Yes, I have a 86 years old female nursing home patient. She was
Yeah.
at the hospital. She has a bradycardia and junctional rhythm. So
Yeah.
EP saw her and then started on theophylline. Her heart rate improved. Is this something that we have to continue and check the level and adjust the medications?
Yeah, we've done it, me and Steve at the Kindred. Steve knows about that. Probably he's sleeping right now. So we start actually, we do it at Kindred, but you really need to check the levels. The theophylline medication need came from asthma treatment. It was great asthma medication, and actually they still use it back home in Syria, for instance, in South America and other developing countries. We don't really use it very much here because of the toxicity. So we need to check level. If we deem this patient in need for theophylline, in America, the way we treat that nowadays is pacemaker. But if you think that for whatever reason, pacemaker is not going to be indicated as of now, then you're going to use theophylline beyond 1 week, 1 to 2 weeks, then you need to check the dose level. I'm sorry.
Right. So if it's less than 10 to 20 is a therapeutic range. If it's 3, do I need to adjust the medications now that her heart rate improve, or just leave it the way it is?
No, if it is actually high, you gotta probably lower the dose or make it every other, whatever, cut down the dose or cut down the frequency.
Okay.
We can't have a theophylline toxicity though.
Okay.
Why don't we use atropine ever?
No, dude, atropine is the half-life is 1 minute. So you can't use atropine, and you can use its IV medication, obviously. Yeah, but no, if we think that medication, the patient has sinus node dysfunction, symptomatic, in that case, pacemaker is needed. We use it sometimes for patients on the ventilator. They have high vagal tone. It's very difficult to wean off the ventilator. You use it sometimes, buy some time and stuff like that. Patients may be septic, like typical Kindred patient, but we don't really like to. I've never used it outpatient because, if you feel that there's sinus node dysfunction or conduction wire disease, then in that case, pacemaker will be needed.
For patient with chronic atrial fibrillation, is there indications for cardioversion if the rate is controlled?
If you look at the guidelines, yes. You have to give your patient one chance. at least chance of rhythm control.
Okay.
Now, if you think, if your patient, nursing home patient that bedridden or minimal functional capacity, you can get away with it. But, you know, if you look at the guidelines, newly diagnosed atrial fibrillation, it's really reasonable to consider rhythm control strategy in this patient, i.e. cardioversion, because the yield may be high and the side effects are really small.
Okay.
I have a question.
Yes.
Yeah, in the rehabs, do you hold anticoagulation when anemia is getting
Absolutely.
pretty low? Like I have some patients that are in the 7s and 8s.
Absolutely. Yes.
And they have atrial fibrillation, they have a history of PE and DVT, still hold Eliquis.
Yes, I mean, it doesn't make sense that you're giving blood thinners and at the same time you're doing blood transfusion, you know?
They're actually not getting blood transfusions until they go below 7, then they send them out. They're giving them maybe Procrit and some oral iron, but they're letting them stay at about around 8, which
So if somebody chronically around 8, you know, I would really lower the dose as to use something like Eliquis 2.5 twice a day and something like that. You know, you get to individualize it, and hemoglobin of 8, I'm not sure if you've ever experienced that, but I've seen it in a lot of patients. You know, you're gonna have zero energy. You're really gonna suffer a lot. And you know, unless you have massive PE, in that case, you know, we may need to just keep the medication, hope for the best. But if we think that there's really decrease in hemoglobin to the point that this patient may require transfusion, in that case, I think stopping the anticoagulation is a reasonable option. But always remember that a lot of patients, they keep taking aspirin, even though they don't really report that, or they just take aspirin along with other medications, and physicians will not pay attention to that. There's a trial called Averroes trial. I think it was done in London, in Britain, and it made it all the way to Lancet. I think 2011, 2012, 2013 kind of Lancet journal. And they found that the risk of bleeding from aspirin was similar to the risk of bleeding from Eliquis. Now, the trial was stopped early because of the effects of Eliquis compared to aspirin. But, you know, they did not really follow patients very long. But I can tell you that the aspirin is not a benign medication. So keep that in your mind. If your patient AFib or PE, and they have stable coronary artery disease, remote stenting, stuff like that, I really don't think this, especially if anemic, I don't think this patient needs to stay on any kind of antiplatelet agent. I think the low dose Eliquis should take care of that. But
take
if you
away the Plavix and the aspirin, leave the Eliquis and see if they come up a little bit, and then
damn right, yes, yes. Eliquis, there's indication for Eliquis because actually long time ago in the 90s, they found that warfarin actually is as effective as aspirin, Plavix, or antiplatelet agent. There was no Plavix back then. Antiplatelet agents in preventing MI, but the bleeding risk was 7 times higher. In other words, you know, these anticoagulation, they can really protect from CAD to a certain degree.
okay, thank you.
Any other questions, guys? All right. Okay, so let us know. Let Nick know if you really need to have, each one of you need to send a topic of interest to Nick. How about that? And then we'll start actually, you know, talking about these topics. This is the only way that we can get educated. You know, all of us are busy doing a lot of stuff, but you guys acting like cardiologists, and you should have enough knowledge to be able to act like cardiologist provider. So, you know, feel free always to chat with us, text me, call me if you have any question. And I know Whitney all the time, if she has questions, she reached out to me. And some of these cases are really very difficult. You really need to think about it. And we'll chat later next week or the week after. Thank you, everyone.
Okay.